بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. أبنائي إخواني أعزائي الطلبة، يتجدد بنا اللقاء في الجزء الثاني من محاضرة Keratoconus Comprehensive Guide and Updated Review in all keratoconus subject. Now, as I said before, that the second lecture will be related to the treatment modalities for keratoconus, and we will speak in this lecture regarding the corneal cross-linking. We will discuss all the details regarding cross-linking, starting from the historical prospect and the theory behind cross-linking, and the basic indication, contraindication, complications of corneal cross-linking. Also, we will speak about the different protocols available and the different generations from first, second, third, and fourth generation corneal cross-linking, and also the combined protocols. And we will emphasize on the concept that cross-linking is not just for maintaining the corneal stability, because before it used to say that corneal cross-linking is not a refractive procedure. It is just to maintain the shape and stability of the cornea. However, recently it is discovered that it has a role in improvement in the visual function of the patient. So it has a role in improvement in the visual acuity of the patient, especially in the combined protocols like the LASIK extra and the PRK extra and so on. So we'll discuss all the details regarding the cross-linking and the recent advances. Also the use of extracorporeal corneal cross-linking and the all femto caries, and all the recent advance in the corneal collagen cross-linking. So this lecture is very important, full of information, especially for postgraduate students and those who are practicing in the different eye departments. So I advise you to concentrate on this lecture and write down all the important informations, and let's dive deeply and see what's inside. Looking forward to meet you soon in another session. And the next lecture will be about the intracorneal ring segments implantations. So I hope that you will benefit from this lecture, and let's go and see what's inside. Before I start the lecture and explore the details of the corneal cross-linking, I just like it to remind you with this hierarchy that you are familiar with it, as we explain it in the lecture of Comprehensive Guide on Keratoconus. Now, why this lecture is important? Because as we said before, that the management of keratoconus based mainly on these three squares and this hierarchy. That's we have to stabilize the disease first, then we have to improve the shape of the cornea and the topography, and at the end we have to improve the visual function and improve the visual quality. Now, the importance of that cross-linking before, it was thought that it is just for arresting the progression of the disease and improving the topography only. However, recently with the evolution of the customized corneal cross-linking and the high fluence cross-linking, so that we can also improve the visual function of the patient using the corneal cross-linking. Also, we are in the era of LASIK and refractive surgery, and because of the safety of the cross-linking, we can combine the cross-linking with different visual correction, laser vision correction techniques like the SMILE or the PRK or the LASIK. So now the cross-linking will cover all these aspects in the management of keratoconus. It is important in arresting the progression of the disease and secure the stability of the cornea. And also it is important to improve the shape of the cornea and regularize the surface of the cornea. And also it has a major role in improving the visual function by itself, by the cross-linking itself, or in combination with other laser vision correction, as I said, which is known as LASIK extra or SMILE extra or PRK extra. So this hierarchy is very important because cross-linking will cover all the aspects of this diagram. The Young's elastic modulus is an index used to express or specify the stiffness of the cornea, and it is given this name after the work of Thomas Young's and given the letter E. And it is defined by the ratio between the longitudinal stress and strain. As you can see here in this diagram, when there is an elastic structure here, so there is as you can see, a linear relationship between the stress and the strain of this structure. In the case of cornea, as it is a viscoelastic structure, the stress comes from the intraocular pressure. So there is a linear relationship. The more the stress, the more will be the strain. But up to this level, this is a reversible part, that the structure, once the stress is removed, the structure will return to its original shape. However, beyond certain points, now the structure will lose its elasticity, and when the stress is removed, it will not return to its original state. And the more the Young's modulus, as the blue color here, is indicate that the material is stiff, and the more is the slope, like in the red color here, indicate that the material is elastic. So when we say that large Young's modulus, indicate that it is more stiff. This is what happens after cross-linking, that we increase the Young's modulus. Now, this linear relationship is not applicable to the cornea, because the cornea has non-linear relationship between strain and stress, as we can explain here. So, as I said, that the cornea is a viscoelastic structure which has a non-linear relationship between the stress and the strain, also known as hyperelastic. That's to say that the loading and the unloading have different paths. And as I said, the stress in the cornea comes from the intraocular pressure. It means that for each particular pressure, there is a special strain exerted in the cornea, and we have more than one Young's modulus based on the different stress levels. So as the intraocular pressure increase, there will be increase in the longus modulus, and the cornea becomes more stiff. And this is very important fact, that the more the intraocular pressure, the more is the stiffness of the cornea. And all the parameters that we were discussing regarding the curvature of the cornea, the thickness and the elevations, that changes that happens in keratoconus, all these changes are secondary to a primary defect in the corneal biomechanics, or focal defect in the biomechanics of the cornea. This is the theory behind the etiology of keratoconus. That's in keratoconus, it is a focal defect in the corneal biomechanics, which will lead later on to the secondary changes in the thickness and the curvature and the elevations of the cornea, based on the biomechanical decompensation, the cycle of biomechanical decompensation that we have explained before, that you have a focal defect in the cornea based on the longus modulus. They determine a focal defect usually in the apex of the cornea, and this focal defect will lead to redistribution of this stress made by the intraocular pressure, and this redistribution will lead to increase in the curvature of the cornea, and again this will redistribute the stress again, and this will lead to increase in the strain, and exemplified by the thinning. So the changes in the cornea in the form of thinning and decrease in the pachymetry and increase the curvature of the cornea in the cases of keratoconus is secondary changes, secondary to a primary defect, which is a focal defect in the corneal biomechanics, as explained by this theory. The CXL is defined as corneal collagen crosslinking, which is abbreviated as C3R. C3 means three letter C's, corneal collagen crosslinking. And this is an FDA approved technique, which is a minimally invasive photodynamic interaction that utilizes the ultraviolet and along the riboflavin as a photosensitizer. This will induce a chemical reaction within the stroma and release of certain oxygen radicals that lead to cross-linking between the collagen fibers, and this will increase what's known as the Young's modulus of the cornea. So the Young's modulus is an index of stiffness of the cornea, will be increased in cross-linked cornea, so that, as you can see here, this cornea has a high viscoelastic property. Now after cross-linking, it becomes some sort of stiffness. And this stiffness will increase the rigidity, as well as this will increase the flattening of the cornea, so that the steep part of the cornea will be flattened. And by this way, we improve the curvature of the cornea and the anterior surface of the cornea. So the main goal of the corneal collagen cross-linking is to halt the progression and arrest the progression of keratoconus by increasing the Young's modulus, or the stiffness of the cornea. Now, as we used to say, always a few words about the history of the technique that we are speaking about. Now, as far as the cross-linking, the history is dated back to the early 19th, and the idea is inspired by the Thiociller, who is regarded as the father of this technique. Thiociller inspires this idea of using the ultraviolet rays for the cross-linking of the corneal collagen while he was visiting the dentist, who notes that he's using the ultraviolet to do cross-linking for the or strengthening the gums. So there was a scientific team from Dresden University at Germany, led by Professor Thiociller, who did a lot of experiments on animals utilizing the ultraviolet to do cross-linking of the cornea. And this work was first presented by the annual meeting of the Association for Research in Vision and Ophthalmology, abbreviated as ARVO, at 1996, and the result was as a revolution in the treatment of ectatic corneal diseases, namely the keratoconus, where the work of Wollensack, who is one of the members of the team of the Thiociller or Dresden University. Thiociller, Wollensack is not a ophthalmologist; he's a scientist who did the work in the lab, and at 2003 introduced the CXL as a minimally invasive procedure to halt the progression of keratoconus, and at 2005 the first commercially available CXL machine was available in the market, made by Bushka company from Germany. So this is in brief the history of cross-linking as inspired by Thiociller and supported and backed up by the work of Wollensack. And it was, as I said, a revolution in the treatment of ectatic diseases, namely the keratoconus and other diseases. The basic information about the cross-linking and the collagen cross-linking was explained by the Professor Thiociller, as we said before, and he explained that there are different types of cross-linking. One which is known as physiological cross-linking, which is usually happens in the body and is usually enzymatically mediated by a special enzyme known as lysyl oxidase enzyme. And this happens as a normal physiological process, happens in the whole body when the collagen fibers are translated from the nucleus and excreted to the extracellular space of the cells. So that this is called post-translational. That's after the translation of the collagen fibers, it will take the final shape and the elastic property by this enzyme, that's lysyl oxidase. And this explains why there is a decreased incidence of keratoconus as we grow up and in old age, because there is a physiological cross-linking that happens in the cornea by the help of this enzyme. And also, there was different studies done by different people that they show that lysyl oxidase enzyme is important in the process of physiological cross-linking by certain mechanism that it will react with the aldehyde group, which is present in certain amino acid terminals at the collagen fibers, and this will lead to the spontaneous cross-linking. This aldehyde group this reaction called aldol condensation. And another work done that shows that the keratoconus, one of the theories behind the keratoconus, that it is a genetic defect in the lysyl oxidase enzyme, as exemplified by that people with Ehlers-Danlos syndrome, they have deficiency in the activity of this enzyme, and hence they have a high chance for having keratoconus. So some people, they try to find out a link between the defect in the genetics of that code for this enzyme, that's the lysyl oxidase, and incriminate it as a cause for the keratoconus. And another thing, or conversely, that they found that in people with keloid, as you know, keloid, there will be an excessive scar formation, and the scar contains the collagen fibers. they have excessive activity of this enzyme, which is the lysyl oxidase. So they try to relate the appearance of the weakness of the cornea related to this enzyme. Another type of cross-linking, which is also happens in the body, which is related to the advanced glycation end products, which is the end products of the end stage of metabolism of glucose and ribose and the glyceraldehydes in the body. These end products will lead to glycosylation of the collagen fibers as well, but this is a very slow and weak reaction. But they utilize this to explain why people with diabetes, they have low incidence of keratoconus, and this is related to the advanced glycation products that's seen in patients with hyperglycemia and patients with diabetes. Now, the third type of cross-linking, which is mediated by the ultraviolet, which is also known as physicochemical cross-linking, that is a photooxidative cross-linking mediated or induced by ultraviolet in the presence of photosensitizers. They have found that this reaction is safe, and it has a major effect in the strengthening of the collagen fibers, as seen in utilizing these techniques in the dentist to strengthen the gums. And that's why Thioceller chose this type of cross-linking to be applied to the corneal collagen cross-linking. That's the photooxidative type of cross-linking mediated by ultraviolet and a photosensitizer. Some people, they name it as a photodynamic therapy for the cornea, photodynamic therapy. Now, if we speak in details about the detailed mechanism of the cross-linking of the collagen fibers upon impipation of the cornea with the riboflavin, which is the photosensitizer, and then gets stimulated by the ultraviolet rays. Now, there will be a set of reactions will happens inside the cornea that finally will end up with the formation of strong cornea, stiff cornea, and what's known as the increase in the Young's elastic modulus. Now, there are mainly two reactions happens, which is the non-oxidative pathway, which is enzymatically mediated glycosylation, which is this is a very weak pathway, and the other, which is the oxidative pathway, which is the more important one. Now, the oxidative pathway can be of three types: type 1, type 2, type 3, based on the contribution of the riboflavin radicals or the excited states, and also the contribution of the oxygen free radicals or oxygen reactive species. So the oxidative pathway can be of type 1, type 2, or type 3. And type 1 usually known as anaerobic pathway, which is mediated by the excited riboflavin species in the triplet state. So this will lead to activation of the amino acid terminals in the collagens and lead to the cross bond between collagen fibers. The type 2 reaction, which is oxygen mediated. Now, this is lead to the formation of oxygen free radicals or reactive oxygen species, and also the same way it will lead to the cross-linking. Type 3 also, it is mediated by riboflavin active free radicals, and is a combination of type 1 and type 2 based on the concentration of the oxygen. And at the end, there will be stiff cornea and increase in the Young elastic modulus. This is the detailed reaction that happens during cross-linking. In this diagram, it shows the absorption coefficient and the absorption spectrum of the different layers of the cornea, as published by one of the studies in the ARVO journal, and it shows the ultraviolet absorption of the human cornea as a function of the different wavelengths of the spectrum. As you know, the ultraviolet A, ultraviolet B, and ultraviolet C. This is the usual range for ultraviolet A between 330 and 400, and ultraviolet B 280 to 330, and ultraviolet C 240 to 280. So in this study, they study the absorption coefficient for the different layers of the cornea, and they want to explore the ultraviolet filtering ability of these different layers to determine the participation of each part in the absorption spectrum of the cornea. and they found that the absorption coefficient for the pomus layer is the highest, followed by the epithelium, and then followed finally by the stroma. So you can see that both the epithelium and the epithelium and the pomus layer have the highest absorption coefficients, especially for ultraviolet C and ultraviolet B. However, the stroma has the least absorption coefficient and nearly equal absorption for the three types of ultraviolet A and B and C. And by studying this effect, they find that although the absorption coefficient of these two layers is high, but their participation in the total absorption and radiance to the cornea is less than that of the stroma. Nearly 75% of the irradiance of the ultraviolet to the cornea is absorbed by the stroma and not by the epithelium and the pomus. And this can be explained because not based on the molecular composition of these two layers, or not related to the absorption coefficient, but because of the thickness of the stroma. The stroma is thick, nearly 10 times more thick than the epithelium and the pomus layer, and that's why they have much more absorption spectrum for the cornea than the pomus layer and the epithelium. Although the absorption coefficient for the pomus layer and the epithelium is higher than the stroma, but their participation in the total spectrum absorbance of the irradiance of the cornea is less because of their thickness. So the stroma has the most significant absorption in the cornea. However, it is not due to its high absorption coefficient, but it is due to its thickness, which is 10 times more than that of the epithelium and the pomus layer. And because of this ideas, now there is a paradigm shift in the cross-linking to compensate for the barriers of the epithelium and the pomus layer for the absorption of the ultraviolet by having high fluence ranging to 7 joules up to 10 joules to compensate for this limitation for the absorption of the ultraviolet. Now this diagram will explain and show you the absorbance. So you can see here clearly that although the pomus layer and the epithelium, they have high absorption coefficient, but the absorbance for the stroma is much more as compared to the other layers. And this is, as I said, because of the thickness of the stroma, not related to the absorption coefficient. Now, after many years from the suggestions of Theo Siller regarding the benefits of utilization of ultraviolet energy along with riboflavin in cross-linking of the cornea, the doctors realized the importance of cross-linking, and they discovered a new advantages of the corneal cross-linking apart from its corneal biomechanical stiffness and increase in the Young's elastic modulus, that's the stiffness of the cornea. They found that it has important role in as anti-proteolysis and anti-collagenase activity. So it's useful in counteracting the melting of the cornea. Also, it has a role in managing or decreasing the corneal permeability, so that decrease the interfibrillar spaces and decrease the hydration of the cornea, so that it has role in the management of some cases of Hox endothelial dystrophy and cases of chronic corneal edema following corneal rejections. And also it has an anti-infectious effect, as it has used in inducing a irreversible intercalation between RNA and DNA segments, so that lead to killing of the organisms, namely the fungi, in the what's known as the BAC-CXL, as we have spoken in this on the lecture of fictitious keratitis. BAC-CXL stands for photoactivated chromophores for keratitis. Now this is beyond the scope of this lecture. We will concentrate on this lecture in the use of riboflavin and ultraviolet energy in the classical or in the improvement in the corneal topography and in the improving the corneal biomechanics. So there are various important determiners for the successful crosslink technique that we will speak on them one by one, so that it makes the backbone of this lecture, which is namely the epithelium, the various types of cross-linking, either epithelial on or epithelial off, and also the ultraviolet radiation and the different intensity and doses and the beam profiles. Also, we will speak about the applications of riboflavin and the different ways to improve the permeability of the cornea for riboflavins, and also the availability of oxygen and the supplement of oxygen during these procedures. Also, we'll speak about the corneal thickness as important role in the successful cross-linking techniques, and also what's known as the cross-linking saturation effect that determines the benefit or the efficacy of the cross-linking. So we will dive deeply in this lecture and speak on details, especially about the determinants of successful cross-linking, and we will see how we can improve the efficacy of cross-linking by modifying these variables. So if we look to the fundamental concept of corneal cross-linking, we can understand the essential component of the cross-linking, which is the main thing is the photosensitizer, which is usually the riboflavin or vitamin B2, and we need the light source, which is ultraviolet A, with absorption peak of around 370 nanometer, and of course we need the oxygen, which is important for the creation of the free radicals after the photosensitizer get activated, so that this free radicals will create a chemical reaction with subsequent bonding between collagen fibers and lead finally to the stiffness of the cornea. Now, as far as the photosensitizer, which is the riboflavin, we need to have an adequate concentration within the stroma, and since it has a large molecular size, so that the tight junction between the corneal epithelium will prevent the penetration of this sensitizer to the cornea in a sufficient concentrations. That's why in the standard protocol, that's the Dresden protocol, debridement of the epithelium is an essential step in the procedure to achieve a good concentration of riboflavin within the stroma. We will discuss later about the AB on and AB off, but this is as far as the standard protocol, we need to have debridement of the epithelium to achieve a good riboflavin concentration. Now we will speak about the first determiner of the corneal cross-linking, which is the epithelium. The epithelium is very important superficial structure of the cornea with very tight junctions, and the epithelium acts as a very strong barrier against the ultraviolet. Around 25% of the absorption of the ultraviolet is taking place at the level of the epithelium and the pomus membrane, and that's why even the riboflavin and the oxygen penetration is limited due to the tight junction between the epithelial cells. As you know that the riboflavin is hydrophilic and the epithelium is lipophilic, so the penetration will be retarded and mainly is dependent on the intercellular spaces. And these are intercellular spaces are backed by very tight junctions, that's the hemidesmosomes, so that the penetration of riboflavin is much limited by the presence of tight epithelial junctions. So on the epithelial off protocol, that's the Dresden protocol, the penetration of the riboflavin is better. That's why many studies done as a cohort studies or retrospective studies, and they shows that there is a marked increase in the efficacy of the cross-linking in the epithelial off protocols, may be related to the good impipation and the concentration of the riboflavin within the corneal stroma because of the absence or the removal of the epithelium, as compared to the epithelial on, which is the transepithelial technique, which faces this drawback due to the absorption of the riboflavin. That's why many companies and many doctors are trying to change the concentration of the riboflavin and add certain molecules to enhance the penetration and the absorption of the riboflavin. Now, the riboflavin, the epithelium removal can be done by various methods. Can be done mechanically, just by the scalpel blade, or can be some doctors, they use the alcohol, they apply the alcohol on the surface, ethyl alcohol on the surface of the cornea, and then they sweep the epithelium with the cellulose sponge to remove it for around 8 to 9 millimeter in diameters. Always try to preserve and keeping the epithelium over the limbus to protect the limbal area. Or recently they use also the laser as a PTK, phototherapeutic keratotomy, to remove the initial 50 microns of the cornea, which is belong to the corneal epithelium, and they found that there is much improvement in the penetration and the absorption of the riboflavin. As I said, that many attempts done to improve the permeability of the cornea to the riboflavin by adding certain materials to the riboflavin preparation, namely the benzalkonium chloride in the sodium editor, the true metamol, and these will weaken the tight junctions between the epithelium and enhances the absorption of the riboflavin. Also changing the physiochemical property by enhancing the absorption using the ionophoresis, in which the change the electrical charge of the riboflavin so that it will be attracted by the negatively charged epithelium and enhance the absorption of the riboflavin. Also by delivering the riboflavin with different concentrations, reaching up to 20 and 22%, or by direct inoculation of the riboflavin to the stroma and bypassing the epithelium, as happens in the stromal pocket done during the laser femtosecond pocket during the SMILE procedure. All these procedures done to enhance the absorption of the cornea for the riboflavin. Now, there are certain presumed advantages of the epithelial off protocol, which shows the better absorption of the riboflavin, deeper and more effective treatment, and more corneal stiffness and flattening, and improve the corneal biomechanics by this classical Dresden protocol. Also, there are some presumed advantages of the epithelial on technique, in which there is rapid rehabilitation of the patient and rapid recovery to the use of the contact lenses, and less pain as compared to the epithelial off technique. And also that we can do the technique as an outpatient technique with bilateral treatment for both eyes, because a minimum risk for infection. However, there are certain drawbacks or disadvantages reported for the epithelial off technique, which is on the top is the pain, which is perceived by the patient due to removal of the epithelium. Also increased the risk of infection, both the sterile and non-sterile infections, and also the risk of persistent epithelial defects. Also the delayed recovery of the patients, because he will need to follow the doctors for complete healing of the epithelium, and also the perceived haze after the procedure, and also that you cannot do the two eyes at the same time, and you need the major theater to do this procedure to avoid the risk of infections. So you need to do one eye, and after 2 months or 3 months you do the other eye, unlike the in the epithelial on technique. However, the epithelial on technique also has some reported disadvantages due to the less penetration of the ultraviolet and less riboflavin absorption and saturation, and less oxygen penetration. All this will lead to reduced efficacy of the treatment as compared to the standard Dresden protocol with epithelial off technique. So these are the pros and cons of the epithelium as a function in the successful cross-linking technique. As we said before, that the epithelium, the presence of intact epithelium and Bowman's membrane will exert a shielding effect against the ultraviolet penetration, and this is very important determinant factor for successful cross-linking, as stated by the Pierce-Lambert law, that in the presence of intact epithelium, only up to 65% of the exposed ultraviolet energy will arrive to a thickness of 200 micrometer from the cornea, and this amount will be further reduced by the addition of riboflavin, which has another shielding effect for the ultraviolet. So the combination of both the epithelium and the presence of riboflavin will significantly will reduce the amount of penetration of the ultraviolet and reduce the radiance of the ultraviolet energy because of the high absorption spectrum for these two together, along with the absorption spectrum of the stroma. And that's why now when we do an epithelial off technique, we increase the exposure for the ultraviolet, and we increase the absorption of the ultraviolet, and also we increase the absorption of riboflavin to the stroma, so that we aim to enhance the effect or the enhancement of the created by ultraviolet exposure to as maximum as 350 or to 400 micrometer from the thickness of the cornea, so that we can reach to the deeper layer of the stroma. Because in the traditional epithelial only we can reach up to 200 or maximum 250 microns, and this is represent the anterior part and up to the middle part of the stroma. And as you know from the lecture of anatomy of the cornea, that the anterior half of the stroma is the less stiff one, and the posterior part is the reverse. The anterior part of the stroma is the more stiff one, and the posterior part of the cornea is the less stiff one. So in keratoconus, we are aiming to reach to the effect of the cross-linking as deep as to the deeper part of the stroma, which is the weak part of the stroma. The anterior part is already stiffer as compared to the deeper part. So this is two important variables that determine the effectiveness of the cross-linking. That's the epithelial on and epithelial off, and also the concentration of the riboflavin, and what's known as the demarcation line, which is the line which determines the interface between the treated area or where the reaction of the photosensitization taking place in the anterior part of the stroma, from that which is spared in the posterior part of the stroma. The difference in the interface between these two stroma by OCT is seen as a demarcation or a hyperreflective line that's known as the demarcation line. So we use the demarcation line to represent the effectiveness of the cross-linking techniques. Although recently it is stated that the presence or the absence of the demarcation line, this doesn't reflect the degree of stiffness of the cornea, it just reflects the depth of the treatment. However, the changes in the corneal biomechanics is calculated and estimated by another parameters and another indices like the stiffness index, as exemplified by the dynamic Scheimpflug technology, that's the curves Scheimpflug technology that determine and study the corneal biomechanical index, that's the CBI and also the TBI, to show the effect of the cross-linking techniques. And also many studies shows that after a period of time the demarcation line will disappear, and this indicate that there will be no more difference between the cross-linked areas and non-cross-linked areas. And maybe this can be explained by the continuous remodeling process that happens in the stroma over a period of time. So the demarcation line is not a perfect indicator for the successful cross-linking technique. It just reflects how depth you have reached with your photochemical reaction within the cornea. Now in this diagram, it represents the what I have said before, that in the absence of riboflavin and the presence of normal anti-junction of the epithelium, so the ultraviolets can reach up to, we lose 65% of the ultraviolet energy by 400 micrometer, and only 1.9 milliwatt is arrived up to the endothelium. And this is much below the toxic threshold level for the endothelium, which is around 4 milliwatt per square centimeter. And in the presence of the riboflavin up to 200 micrometer, we only 33% will be arrived, and in 0.1 in 400 micrometer depth, we only 0.18 milliwatt will be arrived, which is represent on we lost 94% of the ultraviolet spectrum or irradiance. Only 6% will arrive, and this is also much below than the toxic threshold for the endothelium in the presence of riboflavin. So both the riboflavin and the corneal thickness plays an important role in the photochemical reaction and the enhancement induced by the cross-linking, and that's why they choose between epithelial on and epithelial off is very important. And now, although there is a trend toward the use of epithelial on technique because it is more safer and more rapid technique and less pain to the patients, but this is compromising the effectiveness of the cross-linking technique. All the efforts and the studies done now to use the epi-on technique with improvement in the riboflavin delivery system and improvement in the oxygen delivery and ultraviolet and the irradiance and the fluence, so that we can achieve the same effect as the epithelial off technique. Now we come to the second determiner for the successful cross-linking technique, which is the ultraviolet, as explained by the Thiociller in his classical Dresden protocol. He uses the ultraviolet in the range of 365 to 370 nanometer. And after removal of the epithelium, he used the power of 3 milliwatt for 30 minutes for a total dose of 5.4 joule. He could reach to a very good effect in the cornea. And because of the duration of this protocol is long, that's around 1 hour for one eye. Now doctors try to modify this protocol, what's known as the accelerated protocol, in which they use the same principle and the same technique, but they increase the intensity of the ultraviolet instead of 3 milliwatt to a 9 milliwatt. Of course, there is many studies on different powers and different intensities, but they found that this is the best combination as an epithelial off protocol for 10 minutes, 9 milliwatt for 10 minutes, and they keep the same total amount of radiance and energy level. Now, further refinement and modification of this protocol to achieve faster and better effect is by what's known as the enhanced accelerated protocols. This enhanced protocols based on the principle that we increase the total amount of radius, not only the intensity. So here we increase the intensity reaching up to 30 milliwatts and also the total amount of energy to 7.2 joules. This is known as the enhanced accelerated protocol, which is also an epithelial off technique because this guarantee a very good concentration of the riboflavin inside the cornea. Still furthermore refinement is made to achieve an epithelial off epithelial on technique with accelerated high fluence protocols by improving the way of absorbing the riboflavin, either by increasing the concentration of the riboflavin, adding certain molecules within the riboflavin that enhance its absorption through the intact epithelium, like the benzalkonium chloride, the trometol, and the edita. All these materials will increase the absorption of the riboflavin. Also, they remove the dextran from the riboflavin and they add the hydroxypropyl methylcellulose and the normal saline. Also, there is special protocols for thin corneas. We will explain about all of this in the coming slides. So by enhanced protocols, we mean that we increase the fluence and the total energy, as well as we increase the intensity of the ultraviolet. Also by enhancing the way of delivering the riboflavin, like the use of ionophoresis and the use of high concentration of riboflavins. So generally, we can say that the accelerated, the ultraviolet delivery can be as classical protocols as explained by Dresden, in the Dresden protocol by Thiociller, or by the accelerated protocols, which can be either standard accelerated protocol that we do an epithelial off with a standard, just we increase the intensity of the light, keeping the same amount of energy, or by enhancing the total amount of energy, so increase both the intensity as well as the total amount of radiance, or by the assisted protocols that we use, the contact lens assisted protocols or the lenticule assisted, as in the SMILE and pocket. We will speak about this later in details, but this is general an overview. So the accelerated versus the traditional protocols, as you can see that we can reach to the same amount of CXL using the standard protocols, 3 milliwatt for 30 minutes. However, in the accelerated protocols, we use 30 milliwatts for 33 minutes. If you multiply, this will be equal 90, and this will equal 90. So the total amount of energy will be the same. So this is how we can modify the amount of intensity of energy based on the Thomson-Roscoe law that I will explain in the next slide. Now we come to the third determinant of the successful cross-linking, which is the riboflavin. Now, the riboflavin or vitamin B2 is the photoactivated chromophores. It means that this is a colored material that is when exposed to ultraviolet, it will absorb the specific wavelength of the ultraviolet and get activated and converted to an active riboflavin form, and also release of certain free radicals. These are responsible for the creation of the photooxidative reaction between the collagen fibrils and create the bonds between collagen fibers and lead to the cross-linking. We will speak about the details of this reaction later on, but now just we want to speak a few words about the different types based on the recombinant solution, that's the dextran based, or based on the hydroxypropyl methylcellulose based, or based on the osmolarity, which can be hypoosmolar, isoosmolar, or hyperosmolar. Now, as you know that there is a wide range of applications of the riboflavin, and there are different regimes and different protocols, starting from the standard technique, which is the epithelial explained by Thiociller or the Dresden protocol, to the transepithelial protocol, to the accelerated protocols, and then protocols for thin cornea and for thick corneas. So the one which is explained by the standard technique, which is the Dresden protocol, which is based on the dextran based riboflavin. Now the disadvantage of the dextran that it might lead to dehydration of the cornea if left for a long time in the cornea. That's why during that technique or the procedure you need to do an intraoperative pachymetry to make sure that the residual stromal bed after removing the epithelium is at least 400 micrometer, so that you will not hurt or damage the endothelium. So this is the dextran based. The hydroxypropyl methylcellulase based, it is very useful or to enhance and fasten the propagation of the riboflavin to the cornea. So it is very useful, especially in transepithelial type, and it has advantage that it will not lead to dehydration of the cornea. Now, the classification based on the osmolarity, the hypoosmolar one is usually to unpipe the cornea and useful in thin corneas, and the isoosmolar one is, as we explained in the Dresden protocol, and the hyperosmolar one, which is used in to shrink the cornea, especially in Pollas keratopathy, because cross-linking can be used in corneal edema. Another important point that apart from the epithelium as a barrier for the ultraviolet, also the riboflavin, which is known as riboflavin shielding, it is another barrier for the penetration of the ultraviolet. So if you expose the cornea to the ultraviolet, this will damage to the endothelium. However, when you soak the cornea with riboflavin, riboflavin itself is a barrier for the ultraviolet, so it will not allow the ultraviolet to reach to the endothelium to damage the endothelium. That's why proper soaking of the cornea prior to the exposure of the cornea to the ultraviolet is very important. So as I said before, this is the isoosmolar riboflavin, which is commonly used in the conventional CXL procedure, made up of the riboflavin, that's the vitamin B12, vitamin B2, and it is dissolved in the dextran 20. So you have around 400 milliosmol. So this is the isoosmolar one in a 20% dextran. The one which is the hypoosmolar, it is around 310 milliosmol, because it is dissolved in normal saline rather than dextran, so it is dextran free. So 0.9 physiological normal saline. So this is useful in cases of thin cornea. Now, after our brief discussion about the riboflavin, we can understand that to have a very good effect for the cross-linking procedure, we need to have a good concentration of the riboflavin inside the cornea. As you know, the riboflavin is water soluble, and the epithelium is a major barrier for the diffusion of the riboflavin inside the cornea. And there is another factor is the soaking time. That's the time needed for the riboflavin to reach to a good concentration inside the cornea, because the diffusion is time dependent. So we should know the soaking time for each type of the commercially available riboflavins because this is very important. For example, the soaking time for the standard riboflavin, which uses the dextran as a constituent, is 5 minutes every 30 minutes to reach to the good concentration inside the cornea. And we can confirm this by checking the patient on a slit lamp. We can see the homogeneous diffusion and the green aqueous flare that can be seen by the slit lamp. This indicates that there is a good concentration inside the cornea. So how to ensure adequate concentration or diffusion of riboflavin inside the cornea? There are different ways. Most of the researchers and doctors and companies, they work on this to improve the concentration inside the cornea. Of course, the most common one is by modifying the epithelium permeability by adding some enhancer or what's known as epitheliotoxic, so that it will loosen the tight junction between the epithelial cells, and this will permit more perfusion for the riboflavin to the cornea. On the top of the list is the benzalkonium chloride and sodium edita and tetracaine gentamicins. Another thing is by changing the electricity of the riboflavin by adding a charge or electrical charge to the riboflavin, which will get attracted by the opposite charge in the cornea, so that it will ensure good permeability to the cornea. This is known as ionotophoresis. The other thing is by delivering the riboflavin directly to the stroma after bypassing the epithelium. And this is usually done during the femtosecond surgery and the smile surgery, so that after removing any lenticule from the cornea, they can inject the riboflavin inside the stroma. And by this way, we bypass the epithelium as obstacle for the diffusion of the riboflavin. This is the major 3 ways that we can enhance the absorption of the riboflavin inside the cornea. As far as the types of riboflavin which is available in the market, there are plenty of types of riboflavin. The one which is used for the standard procedure for Dresden protocol with epithelial off, and the one which is used for transepithelium or epithelial on, and some riboflavins used for thin cornea, and also for corneas with bullous keratopathy. There is special riboflavin. So there are different varieties based on the concentration and the osmolarity of the riboflavin. The standard riboflavin, which is the isotonic one, which is used in the epithelial off technique, made up of 0.1% riboflavin and a 20% dextran. And this dextran has a dehydrating ability to the cornea, so pachymetry should be done after application of the dextran, so that guarantee the safety margin of the corneal thickness beyond 400 micrometer. As I said, it should be checked, the thickness should be checked after installation before starting the irradiation with ultraviolet. And the soaking time is every 5 minutes for 30 minutes. There is the Vibix, the Rycroline, and the Midi-Cross as commercial names. Also, there is riboflavin for accelerated cross-linking for short time. It is also isotonic for epithelial of 0.1% riboflavin, but in hydroxypropyl methylcellulose instead of dextran. This will promote the diffusion of the transepithelial riboflavin, and it does not cause stromal dehydration. The soaking time is 2 minutes every 2 minutes for 10 minutes. Similarly, there is the Vibix Rapid and the Medic Cross M. Also, there is another one for epithelial on technique, which is for transepithelial, which is the used in 2 steps. The first step is the application of the riboflavin 0.25% in 1.2% hydroxypropyl methylcellulose in a 0.101% benzalkonium chloride. Soaking time is 2 drops every minute for 4 minutes, and the aim to open the tight junctions, and should not stay for a long time, more than 4 minutes. Otherwise, there will be sloughing of the epithelium. And after that, you start applying the another special riboflavin, the concentration 0.22%, soaking time every 1 minute for 30 seconds. for every one drop every 30 seconds for 6 minutes. The example is the Vibix Extra. Another type of riboflavin, which is the ricroline transepithelial, made from Italian company, a concentration 0.1% riboflavin in a 15% dextran added with edita and trometamol, which facilitate the tight junction to help absorption of the riboflavin. Soaking time, 1 drop every 2 minutes for 15 minutes, and then for 15 minutes within a silicone ring, that you apply a silicone ring on the surface of the cornea and keep the riboflavin for another 15 minutes, so the total time will be 30 minutes. By this way, you enhance the absorption of the riboflavin. These are some of the examples of the commercially available riboflavins in the market. Now we come to an important determinant for the successful cross-linking technique, which is the oxygen. Now, the availability of the oxygen is very important for the proper photochemical reaction, because the presence of intact epithelium, or when you speed up the irradiation time so that you will have decreased the irradiation time with large energy, at that time there will be no time to replenish the depleted oxygen, and this will be reflected back to that the photochemical reaction will not be sufficient to produce the therapeutic effect as seen in accelerated cross-linking. Now, the problem of accelerated cross-linking, that they found that the efficacy is not like the standard Dresden protocol, especially if the power is more than 10 or 9 milliwatt for 10 minutes, and this can be attributed to the depletion of oxygen. The more that you give energy for a very short time, there will be no time to replenish this depleted oxygen for the photochemical reaction, and this will lead to decreased cross-linking. So they start thinking how to either supplement extra oxygen to the patients during the procedure, or doing what's known as pulsed versus continuous fluence. So that by pulses means that if the procedure for 4 minutes, we can do it 1 second on, 1 second off, so it will continue for 8 minutes. But even then, even though they discovered that even with this pulses is still not enough, because it need about 3 to 4 minutes to replenish the depleted oxygen. So from all these studies, they discovered that the 9 milliwatt protocol, 9 milliwatt for 10 minutes is the best for accelerated cross-linking. And if you go for a shorter time, the efficacy of the cross-linking will not be guaranteed. So, and this is, as I said, this is because of oxygen depletion, and the process will be anaerobic. Now, the anaerobic mechanism of cross-linking is very slow and is not effective as in the presence of aerobic cross-linking. Now we come to another important determiner for a successful cross-linking technique is the availability of oxygen. The availability of oxygen within the stroma is determined by the permeability of the epithelium and the Bowman's layer. As you know, there is a tight junction between the epithelial cells, and this will determine the oxygen concentration inside the stroma. Now, if you just know that the partial pressure of the normal air, the oxygen will be around 150 millimercury, and this will be decreased at the level of the epithelium to 120 millimercury, and it is further reduced at the level of the endothelium by 55 millimercury. So you notice that there is an oxygen gradient across the cornea, and this oxygen gradient will be depleted once you do or use a high irradiance cross-linking. High irradiance means more than 30 milliwatt for square centimeter. This will lead to a rapid depletion of the oxygen concentration within the stroma, and hence it will lead to limited efficacy of the corneal cross-linking. For that reasons, and after the doctors they realize the importance of oxygen and the effect of the cross-linking, they start thinking how to overcome the problem of limitation of oxygen availability inside the stroma. One of the idea is to use what's known as the oxygen goggles, as you can see here. This oxygen goggles will secure to deliver a high oxygen concentration during the cross-linking technique, and many studies done shows the great efficacy of this technique to improve the high fluence short time technique by applying high concentration oxygens. Another way you can use the oxygen line, just you put it just beside the eye. Also, they found it is different than without using the oxygen. Another way is to use the what's known as the pulsed ultraviolet radiance. Pulsed means 1 second on and 1 second off. This off time for the radiance will allow for replenishing the depleted oxygen from the stroma. Also, many studies done and shows the efficacy of the pulsed ultraviolet delivery along with the high oxygen concentration, along with the high irradiance of the ultraviolet. But when they studied the physiology of the cornea, they found that for the depleted oxygen inside the cornea, at least you need to wait for 3 minutes to replenish the depleted oxygen. So the efficacy of the cross-linking improved by the use of this technique, that's the pulsed light, but it is not as effective as in the classical Dresden protocol. So as you can see that there are a lot of attempts made by doctors to improve the efficacy of cross-linking just after realizing the importance of oxygen in the efficacy of the cross-linking techniques. One of the investigators, they do what's known as the bubble CXL. That's they inject an intracameral oxygen inside the anterior chamber, and this is to provide oxygen from the posterior surface of the cornea, so improve the oxygen concentration and the gradient within the stroma. But of course, this technique will take the cross-linking technique to another area, which is the becomes an invasive technique. As you know, cross-linking is a non-invasive technique. Now, if you want to inject air inside the anterior chamber, this becomes invasive and takes the risk of infection and all the complications of any surgery. And also, these studies are still under the experimental models, still not applied to human beings. So in general, to sum up this issue, that when you use a high irradiance short time technique, that's high irradiance more than 30 milliwatt for square centimeter, you need to supply an oxygen during the technique to overcome the depletion of oxygen. However, they found that if you use low irradiance, that's below 9 milliwatts per square centimeter, there will be no need for supplying or providing oxygen during the technique. Now we come to an important determinant of the successful cross-linking technique is the corneal thickness. And the corneal thickness is important in many aspects as far as the concentration of the riboflavin, and also for the security and the protection of the corneal endothelium, because if you haven't sufficient stromal thickness, this will endanger the endothelium by the ultraviolet energy, and this will end up by corneal decompensation. So it is recommended that at least 400 micrometer should be available before you can proceed with the cross-linking. And if not, you should choose the ultra-thin cornea protocol or sub 400 micrometer protocol to protect the endothelium. And this diagram shows the efficacy and the safety of the ultraviolet irradiation. As you can see, the concentration of the ultraviolet will decline as you go deeper, so that by the level of 500 microns, you can see minimum amount. And this is for the 400 micrometer, you can only see only 10% of the ultraviolet is arriving to that level, provided that you have a good concentration of riboflavin. So radiance is reduced by 95% at the endothelium, and this will protect the endothelium from being damaged by the ultraviolet. So if you have thin cornea, better not to do the standard protocols. You need to go for another protocols. Now I will speak about a new important concept of the successful or the efficacy of cross-linking is the what's known as the saturation effect. Now the saturation effects means that there is a limited number of free cross-linking sites for the combination of ultraviolet and riboflavin inside the cornea. because cross-linking, the availability of riboflavin and oxygen will be available in sufficient quantities, but the problem of the presence of limited number of cross-linking sites on the collagen fibers and also in the proteoglycans, because cross-linking will happen between the collagen fibers as well as between the proteoglycans of the cornea. Now, from many chemical studies, it is known that the collagen has only a limited number of free reactive amino acid residue for ultraviolet cross-linking. And by cross-linking, the cross-linking density, we can apply we can only increase the density of the cross-linking until the saturation of this amino acid residue terminals in the collagen fibers. Once saturated and cross-linked, there will be no further cross-linking possible between collagen fibers. So that the saturation effect is explained as follows: that the upper part of the cornea, the potential cross-linking will sites are start to do cross-linking with the availability of the ultraviolet and riboflavin and oxygen. And once saturated, the available oxygen will diffuse deeply to the deeper layers. So looking for any free amino acid residue for cross-linking. Once all these free amino acid residue terminals at the collagen fibers are saturated, so there will be no further cross-linking. This is known as the saturation effect or the cross-linking density. Now, if we look to the aim of cross-linking after understanding the biochemical reaction that happens in the cornea and the bonding that happens between the collagen fibers, so the main aim is to increase the elastic modulus of the cornea so that it becomes more stiff, and this will increase the tectonic strength of the cornea. By increasing the tectonic strength of the cornea, we will arrest the progression of the disease and we will improve the bulging and the thinning of the cornea. This is major achievement. That's once you improve the bulging and thinning of the cornea and you arrest the disease, this will lead to improvement in the tolerance of the contact lens, and patient can use contact lens so that he will improve his best visual function. Another thing, that by cross-linking, we arrest the progression of the disease, so we delay the need for keratoplasty. As long as the patient has clear cornea, no active disease, and patient visual function is stable and good by using the glasses or the contact lenses, so there will be no urgency in the doing keratoplasty for these patients. So this is a major achievement using keratoconus, using the cross-linking. Now, what are the indications of cross-linking? Of course, on the top is the presence of progressive keratoconus with significant drop in the visual acuity and worsening of the visual function and corneal thinning. This is a strong indication. Also in children, it is very important to know that in children, we need not to wait to document the progression of the disease to start the cross-linking. Once diagnosed as keratoconus in children, we have to do cross-linking because it is found that in these patients, the progression is very rapid and very aggressive. So we need to do cross-linking as soon as we diagnose the case as keratoconus. Another indication is other non-ectatic diseases like, non-keratoconus ectasia, like pellucid marginal degenerations, Stevens marginal degenerations, and keratoglobus, and so on. Another indications is the what's known as corneoplastic procedures. That is as adjunctive treatment along with LASIK, PRK, BTK, ISR, CK, or as a subsequent procedure to manage complications that's due to post-LASIK ectasia and so on. Another spectrum of the cross-linking is its use in the infectious keratitis, namely fungal keratitis and bacterial keratitis. There are many studies shows that the efficacy of cross-linking in managing cases of keratitis or infectious keratitis without the use of antibiotics. This is what's known as the PAC-CXL. We will speak about it later. Also, it has a major role in the treatment of corneal edema, as it has a dehydration effect, the cross-linking, and also tightening the spaces between the lamellae of the cornea so that it will eliminate the corneal edema. So these are the major indications of corneal cross-linking. but this doesn't mean that there is no contraindication. There are some contraindications also as well, and in the top of it is the presence of coexistent infection of the eye. I mean infections like adnexia, that is like infection of the dacryocystitis or blepharitis, because when you do epithelial off treatment, now the cornea will be exposed and the stroma will be exposed to the pathogens, and there is a chance for uh, uh, infectious keratitis induced by this procedure. Another thing is herpes. Herpes infections is a relative contraindication for cross-linking. There are some cases shows a reactivation of herpes infection after cross-linking, a presence of neurotrophic keratitis as well, because cross-linking might induce some death of the nerve fibers and damage of the nerve fibers of the cornea. So there will be some element of neurotrophic keratitis. So this is another contraindication. Another contraindication is the presence of any disease with poor epithelial healing problem, or in presence of severe dry eye, or any autoimmune disease like rheumatoid arthritis, or any autoimmune disease of the cornea is another contraindication. Pregnancy is not regarded as absolute contraindication because there is no studies that shows any harmful effect of cross-linking during pregnancy. However, it is generally advised that during pregnancy to avoid doing cross-linking. But so far, there is no studies to prove that it has dangerous or hazardous effect during pregnancy. So these are the major contraindications for cross-linking. Now, as far as the complications of corneal cross-linking, of course, there is no 100% safe procedures. Although corneal cross-linking, if we take in consideration the indications and the precautions and the contraindications, it is very safe procedures, and most of the studies done shows 95% of the cases they achieve the goal of achieving corneal stability and biomechanical stability within 12 months. However, some reported cases of the complications has been mentioned, and the top of them is those complications related to the epithelium, either in the form of epithelial downgrowth or epithelial ingrowth if it is the CXL is combined with LASIK procedures. Also, the delayed healing of the epithelium as seen in Dresden protocol. This delayed healing of the epithelium may be due to the ultraviolet itself. As you know, the ultraviolet has impact on the DNA proliferation of the cells, or it might be related to the mechanical effect of the contact lenses. You know, in the Dresden protocol, we place a bandage contact lens, and if this lens is very flat, it will hinder or prevent the healing or the growth of the epithelium. So it is advised to place a little bit more steeper bandage contact lens, so that this will create a gap between the contact lens and the epithelium, so this will allow for proper epithelialization of the cornea. Of course, among the dread complications of the corneal cross-linking is the infections. Exposure of the stroma and removal of the epithelium make them exposed to any pathogens, and although the corneal cross-linking itself it is used in the treatment of certain corneal infections, but sometimes the inoculation of certain pathogens inside the stroma directly bypassing the epithelium, this will enhance the corneal infection. And among the other important complications is the presence of corneal haze. Now, this corneal haze might be due to poor selection of the case from the beginning. People with high K reading and old people, they are more prone to the haze as compared to the other cases, and this haze might be transient, which might be a good sign for good epithelial, good effect of the cross-linking, and it disappears within the first month, or it might be persistent for a long time and it needs detailed concentration of steroid therapy, and it might stay for long duration. The exact pathogenesis of this haze is not known, but mostly due to the activation and the excitation of the keratocytes and the induction of the remodeling process inside the cornea and among the collagen fibers. The other problems related to the corneal cross-linking is the failure of your cross-linking, either as a primary failure before the 6 month or secondary failure or late failure. And at that time, you have to decide whether to go for another cross-linking redo or not. Other minor complications include activation of herpes infections and also the presence of dryness. As you know, the cross-linking will induce sometimes dryness of the cornea because of the presence of dextran in the riboflavin, also due to the damage to the nerve ending, which is responsible for the tear production mechanism. So all these are the reported complications of corneal cross-linking. We will speak in details about the corneal haze, as this is an important complication. Also, we will speak later about the failure of cross-linking. As I said, that the corneal, the delayed epithelial healing is one of the important side effects or the complications of the corneal cross-linking, and this delayed epithelialization is seen only in 2 to 5% of the cases, which can stay instead of 1 week, it will stay for 2 weeks. And you can manage the case with the usual management in the form of bandage, contact lens, artificial tears, sometimes use the autologous serum. And should be careful when you use the autologous serum along with the bandage contact lens, because the autologous serum is not sterile, and the presence of bandage contact lens, this will enhance the growth of any pathogens if it is present. Now, the risk factor, as I said, if there is bad selection from the case from the beginning, patients with chronic epithelial problems, delayed epithelialization problems, autoimmune diseases are prone for this. And as I said, if there is very steep corneas, they are more prone for delayed epithelialization. And sometimes we induce the delayed healing because of the bandage contact lens. So we have to use a little bit steeper base curve to allow for space between the contact lens and the epithelium. So if there is element of dryness that participate in this delayed healing, we can use the punctal plugs or preservatives free lubricants along with some steroids. Now, as far as the corneal haze, as I said, it is sometimes commonly it is seen as a transient phase after the cross-linking, and this is indicate a good sign for induction of the healing process inside the cornea that lead to cross-linking. And sometimes it will be delayed and stay for a long time, that necessitate or mandate the use of topical steroids. Also, the persistent corneal haze might seen in patients with poor indications, with thin corneas, and patients with very steep care reading and very old patients. So we should be very careful in selecting the cases for corneal cross-linking. Of course, the treatment in the use of topical weak steroids frequently, so that we decrease this haze, and also to monitor the intraocular pressure, especially in patients with keratoconus, as they use steroids for a long time while they have spring catarrh. So you might induce steroid-induced glaucoma, so you should monitor the intraocular pressure. And also you have to protect the outdoors activities, because the incrimination of the ultraviolet as a reason for this haze is documented. So you have to use sunglasses and ask the patient to limit his outdoors activity. Now we come to an important subject, that is how we assess the success of our cross-linking technique, and how we understand the success of our cross-linking. As you know, that cross-linking revolutionized the treatment of keratoconus, and also treatment of post-keratoctasia, post-LASIK keratoctasia. And it was applied in Europe since 2007, and in the United States is lately accepted at 2016. And from that time, many studies done to explain what are the principles that tell us that there is a successful cross-linking technique, and we have arrested the progression of the disease, and when we need to do another cross-linking for our patients. The next discussions will be based on understanding the corneal cross-linking efficacy principles. As you know, from the era of suggestion of Thiocilla regarding the efficacy of corneal cross-linking in halting the progression of keratoconus,
many companies and many doctors, they start racing to determine how we can objectively quantify the efficacy of cross-linking, because what was available at that time is just a subjective qualitative way for assessing the efficacy of cross-linking based on, for example, on the indirect way of assessing of the efficacy of cross-linking. By indirect way, it means that based on the doctor experience, he can examine the patient and determine whether there is a corneal haze or not, and he cannot exactly quantify the degree of this corneal haze and is it proportional to the efficacy of your cross-linking technique or not, or due to another variables. Also, by the evolution of the anterior segment OCT and the corneal topography, also the determination of the depth of the demarcation line. Now, the determination of the depth of the demarcation line also is an indirect way of assessing the stability of your cornea, because it reflects how deep is your photochemical reaction has been achieved using the ultraviolet and the riboflavin, but this doesn't mean necessarily that your cornea is stable or stiff. So all these are indirect way of assessing the stability of the cornea. Now, the paradigm shift was toward changing the assessment of the efficacy of the cornea from the qualitative subjective way to a quantitative objective way, using some other important parameters that's directly assessing the stiffness of the cornea based on the Corvus ST machine, measuring the stiffness parameters, what's known as the strain stress index, and also the biomechanical stability using the what's known as the biomechanical factors, the CBIF, and also other way of using in vivo confocal microscopy and the application of the Prolwein microscopy. So generally, we can classify the assessment of the efficacy of your cross-linking by a direct way and indirect way. Indirect way using the slit lamp or using the anterior segment OCT to determine the depth of your demarcation line. But the more quantitative and objective way is to use the direct way, which is directly measuring the stability and the stiffness of the cornea by using the stiffness parameters and using the biomechanical parameters. So in our next discussion, we'll concentrate mainly on the different parameters that objectively quantify the stiffness of your parameters and can tell you or answer the question whether your cross-linking technique is effective or not. Now, as I said, that the trend is toward to shift the assessment of the efficacy of the corneal cross-linking from the subjective qualitative way of assessing the efficacy to an objective quantitative way. We spoken before about the corneal haze. Now I will add some few words about the demarcation line or the depth of the demarcation line. As I said, that the different parameters for assessing the efficacy of the corneal cross-linking can be divided into a direct way or indirect way. The direct way, that's directly you assess the corneal stiffness, the corneal biomechanics, and the by in vivo microscopy or Prolwein microscopy, or by the certain stiffness parameters. This is a direct way. However, the indirect way that we examine some other parameters that indirectly will reflect the stiffness of the cornea. One of these indirect ways is the determination of the demarcation line depth, and this is determined by the confocal microscopy or by the use of the anterior segment OCT. Previously, the presence of the demarcation line was an indicator of the success of your cross-linking. However, many studies done and they shows that there is no statistical significant correlation between the stromal central depth of the demarcation line and the outcomes of the corneal cross-linking parameters, that's the stiffness parameters, over 12 months period. And that's why the interpretation that the demarcation line depth is a predictive value for the efficacy of the corneal cross-linking is no more valid. So demarcation line, it is just indicative that there is a a hyperreflective line, which is indicative of the oxidative stress and the healing response that happens inside the cornea due to the exposure to the ultraviolet along with the riboflavin. However, it doesn't necessarily mean that your cornea is sufficiently enough to halt the progression of keratoconus. This is should be very importantly and clearly understood, that even if you find a good demarcation line inside your OCT, this doesn't mean significantly that you halt the progression of the disease, and you still need to assist the patient as far as the stiffness parameter to comfortably say that this patient is safe and there will be no more progression. So this is very important to be understood. Now, as we understood that the keratoconus is due to focal defect in the corneal biomechanics, and the doctors, they could measure the corneal stiffness in vitro in the area of the cone and outside the cone, and they can demonstrate that there is difference between the intact cornea and the part of the cornea which is diseased, that's the cone of the cornea. So this difference in the Young's elastic modulus has led to the speculation that keratoconus is due to focal defect in the corneal biomechanics, and if we can manage this focal defect, we can arrest the progression of the disease. The problem that was facing the doctors at that time is that they cannot measure the Young's elastic modulus in vivo, that's in a human being, outside the labs. All the studies done on human corneas or in animals, they was at the lab. Now, recently, the Corvus company, they could classify the stiffness of the cornea is due to different variables, mainly the geometric stiffness and the material stiffness. Now, the geometric stiffness is related to the thickness of the cornea and is related to the curvature and diameter. The more the thickness, the more the stiffness of the cornea, and the more the curvatures, the more is the stiffness, and the less the diameter is the more the stiffness. All these variables can be quantified and measured by tomography or by Shane flow technology. There is no problem. Now, the problem was how to measure the material stiffness, which is related to the material itself, because as I said before, that the cornea is a viscoelastic structure and it has different Young's elastic modulus for different stress, that's the intraocular pressure. So there is no linear relationship between the stress and the strain exerted by the cornea. So is not that easy to determine a fixed value for the Young's elastic modulus for the cornea. But they define this variable as the material stiffness, and now recently it could be measured as the stress stiffness index, which is the SSI. Now, the SSI is the representative for the material stiffness, so the whole equation could be completed. That is, the geometric stiffness can be quantified, and also the material stiffness can be quantified, so we can reliably measure the stiffness of the cornea all over the surface of the cornea. And not only this, they could represent this figure into a two-dimensional maps, so that we can study the different points of stiffness in different parts of the cornea, within the cone and outside the cone. So they could recently demonstrate the stiffness map, that's SSI map, that's stress strain index map. And as you can see here, this is two-dimensional representation. This color indicate that the homogeneous uniform stiffness of the cornea, and this is a focal defect in the stiffness of the cornea. So by this way, we can study in details and determine if there is any progression of the keratoconus, and also study the efficacy of your cross-linking, whether this stiffness is improved or decreased, or still there is worsening of the stiffness of the cornea. So by this discovery, it was easy for the doctors to early detection of keratoconus, and also to plan strategy to arrest the progression of the disease. So this SSI, they plot this map from a single value into a two-dimensional map, and this map provides an estimation of the regional variation in the biomechanical stiffness of the cornea, so we can determine the stiffness of each part of the cornea. And as I said, that SSI is a measure of the material stiffness, which was deficient previously, and doctors was not able to determine this material stiffness. Now it is easy to measure this SSI. Also, this opens the potential for assessing keratoconus progression, and also not progression, but customize the cross-linking treatment, so that we need not to do cross-linking for the whole parts of the cornea. We just concentrate our treatment on the affected part of the cornea. This is known as customized cross-linking treatment. This is the future of cross-linking, that we have customized cross-linking as well as customized vision correction, so that we will achieve a best result, improving the shape and the geometry of the cornea, as well as improving the visual function of the patients. Now, this microstructure, another observation, they observed that the microstructure of the cornea outside the cone is similar or to the normal healthy cornea, and the abnormality in the cornea in patients with keratoconus is only related to the cone area and related to the thickness of the cornea. So we can quantify and point exactly to the area of defect. And as I said, that the keratoconus is due to a focal defect in the corneal biomechanics. By determining that point, we can exactly treat that point and arrest the progression of the disease. This is the maps, as you can see. This is for healthy cornea, and this is for mild keratoconus, and this is moderate, and this is severe keratoconus, and this is the SSI map. You can clearly see that there is a focal defect here in the SSI map in this patient. This is a moderate keratoconus, and this is a severe keratoconus. So our treatment should be concentrated on this area only. So if you compare, this is the normal cornea, and this is a focal defect, very mild, and this is very severe. The observation that the cornea outside the defect is normal. You can see that the mean SSI in the area inside the cornea is 0.81, and now there is a progression, so that there is deterioration in the SSI index to a 0.63. And this is more the differential map, the difference between this one and this one. Now you can see that the SSI index is decreased from this visit to this visit, so there is clear worsening of the case. However, the cornea outside the cone is nearly the same. The SSI map is the same. So this is confirm our conclusion and the observation done by the doctor, that only it is a focal defect in the corneal biomechanics, and there is no problem outside the cone. Now we come to the another way of indirectly assessing the efficacy of our cross-linking, which is performed by most of the doctors, is by the use of tomographic data, namely the pachymetry and the Kmax and the K reading, and also the improvement in the high order operations and the barometry. Now, it should be kept in mind that when we want to study the efficacy of our corneal cross-linking indirectly using in the tomographic data, we should keep in mind that within the first month after the cross-linking, all the parameters will be worsened. Now, as you can see in this curve, based on the United States phase 3 clinical trials, that within the first month, all the parameters will be worse. Now, as far as the pachymetry, the visual acuity, the K reading, and also the operations profile, all this will be worse, and this should be explained to the patients before you start the procedure. And this is expected and can be explained due to the unmasking effect of the epithelium after you remove the epithelium and you do your cross-linking technique. As you know, the epithelium usually mask the severity of the bulging of the cornea and the keratoconus, and once you remove the epithelium, you need long time for the remodeling of the epithelium, so that immediately there will be unmasking of the keratoconus, and all the parameters will be worsened within the first 1 month. However, the metric data will be stabilized after 3 months, and you will see improvement in the K reading and the Kmax mainly after 3 months. And as you can see in this study, they study the people who underwent, people with keratoconus who underwent cross-linking and versus people who don't do cross-linking, and they said that within the first 3 months there will be significant improvement in the K reading, and as you can see, this is pre-operatively and this is post-operatively. So you can see that people who underwent cross-linking, they have flattening of the K reading and the Kmax by about 1 diopter. However, the people who don't underwent the cross-linking over a period of time reaching up to 1 year or more, they have worsening of their K reading. So this indicates significantly that cross-linking has improved the topography or the tomography or the shape of the cornea based on this clinical finding. Although these are indirect findings, but they significantly shows that there is statistically significant difference between people who underwent corneal crosslinking and people who are not going corneal crosslinking. Another thing that the benefit of cross-linking not only at the level of the Kmax but also in the asymmetry indices, there will be improvement in the asymmetry indices. There will be improvement in the high order operations, namely the coma operations. As you know, people with keratoconus, they have high order operations, namely the negative coma and the negative spherical operations. So there will be significant improvement in their quality of vision based on the improvement in the operations, and patients will notice the difference preoperatively and postoperatively. Now, if you can see this diagram, diagram shows the patients who comparing postoperatively over 1 year between the high order operations of patients who underwent cross-linking and patients who are not undergoing cross-linking. You can see that there is a significant reduction in the total high order operations between the preoperative group and the postoperative group. And if we specify the details of these operations, which is made up of spherical operations, coma, and trefoil, all these types of operations has been significantly reduced between the two groups, that's the operated group and the non-operated group. So this is indicate that tomographic changes is significantly related to the cross-linking technique. Now, we shouldn't forget in this regard the ABCD progression display that we have spoken about it in the lecture of keratoconus, and this is the hallmark and the golden standard for the tomographic-based assessment of the efficacy of your cross-linking, especially the new version or the latest update of the software where they include the flags for the cross-linking, and they specify the different visits and the confidence interval that indicate that there is significant improvement and your patient is stable or not. Now, this display will show whether your patient practically is stable or he's in a state of a progression based on this ABCD progression display. Although, as I said, that this is an indirect way of assessing the efficacy of your cross-linking, but it is very useful and used by many doctors that shows the arrest of the progression of the disease. This is named as the ABCD progression display. Now, in the next slides, we'll speak about the direct way of assessing the stability of the patient after cross-linking by adding some other parameter which is known as ABCDE. E stands for elasticity of the cornea, and this will be the new version of the ABCD system. That they will include the elasticity and the stiffness of the cornea in this display based on certain linear regression, and we will speak about this later on. Of course, as far as we are speaking about the assessment of the efficacy of the technique of cross-linking, after you did the cross-linking of your patient, you want to assess the efficacy, whether your patient benefited from this procedure or not. So basically, when we speak about the biomechanics, we will speak about the CBI. And the CBI, as you know, this is the corneal biomechanical index. Does not basically, when it is created, is not reflecting the severity or the progression of the disease. It just only tell you whether this is a normal cornea or abnormal cornea. So it is not useful as a staging system or a system for detecting progression or stability after cross-linking. The same thing, the Pellin-Ambrosio deviation index, that's the band display, and the TBI, all of them, they are not useful for set up a progression system or staging the severity of the disease. They just tell you that this is an abnormal cornea, better not to go for laser vision correction. After that, the ABCD staging and grading system came up, and this was basically dependent on the topographic changes. That's the changes in the anterior curvature of the cornea, posterior curvature of the cornea, and the corneal thickness. And as you know, that there are many studies done, and they show that the biomechanical changes of the cornea antedate and precede the occurrence of the topographic or geometric changes in the cornea. So this is in one aspect is very useful for early detection of keratoconus is by establish a biomechanical E staging. E stands for elasticity, so that we can detect keratoconus early and detect abnormal corneas early. This is in one aspect. The other thing, we apply the same principle to determine the efficacy of the cross-linking technique, so that we can compare the elastic changes or the biomechanical elastic changes before and after the procedure. And many studies done in this regard, and they show also that the biomechanical stability antedate or precede the occurrence of the topographic stability. The biomechanical stability, I mean the biomechanical E staging, and the topographic stability, I mean the ABCD staging. Now, the problem that how we convert the CBI to an staging system, they utilize the learning machines algorithm, so that they do algorithmic conversion for the CBI, so that they create a new factor or biomechanical factor, which is known as the CBIF. Now, this CBIF is a useful tool to reflect the stiffness and the elastic changes that happens in the cornea, so that by measuring the CBIF as the first step, we can stage and classify the cornea at what stage by dividing into two different groups similar to the ABCD system, so that we can set up a staging system for the patients. Now, on subsequent visits, we can determine whether this patient is stable or getting worse or better by a frequent measurement of this CBIF, which is the Corbis biomechanical factor, exactly the same way as in the ABCD. And now they start incorporating this CBIF or the E staging system in the ABCD system, so that it makes sense to name it as ABCDE. E stands for elasticity, exactly as I show here. So incorporating the E staging system in the ABCD system. So this is a combination of both tomographic, geometric assessment, as well as biomechanical assessment. And the E staging system will have similar bars like this on subsequent visits, exactly like the ABCD system, so that a lower value indicate less stiff cornea. So this patient indicate more progression, and the more the bar, there will be the more the stiffness. So this is very high stiff cornea, this is average and moderate stiff cornea, and this is very low stiff cornea. So by comparing the different subsequent visits of the patients after cross-linking, we can know whether the patient is stable or he's getting worse. Now, why we concentrated the biomechanics? Because, as I said, that they found that stabilization of the biomechanics of the cornea after cross-linking is instantaneous. And means that immediately after the cross-linking, they found a remarkable change in the corneal biomechanics, and the stiffness start in the cornea. Unlike the topographic or tomographic changes that happens after a long period, maybe beyond 6 months and up to 1 year, and sometimes you find worsening of the topographic changes immediately after cross-linking, and this is maybe related to the thickness of the cornea. So now the establishment and the introduction of the new biomechanical E staging, also named as the PIST-E, PIST for biomechanical E staging, named as E, along with the ABCD staging system, both of them will be the gold standard for early detection of keratoconus, as well as determining the biomechanical stability, as well as the tomographic stability of the cornea after the cross-linking procedure. And all these informations, you will find it in one article published by the Vincigora et al. Group that speaks about this new factor, which is the Corbis biomechanical factor, that is useful in the assessment of the biomechanical staging of the cornea. Now we come to the next tool, which is recently innovated in the assessment of the viscoelastic property and the corneal biomechanics after the applications of cross-linking, which is named as the Prolwin microscopy. And for ophthalmological use, it is known as Prolween Optical Scanner System, as POS, which is a combination of confocal microscopy with Prolween spectroscopy and what's called VIBA, which is the amplification of the rays. Now, this newly invented modality of imaging of the cornea, it provides information about the viscoelastic properties of the cornea. It is a non-invasive, non-contact way of evaluating the corneal biomechanics, in contrary to the other available ways of assessing the corneal biomechanics using the sham flow technology, namely the Corvus ST, which based on the mechanical deformation of the cornea and stimulation or decompression of the cornea using the air puff tonometer, and then we study the concavity of the cornea and the stiffness of the cornea based on this physical deformation. Now, in the Prolween microscopy, it depends on another principle. I will explain about it, but just I like it to say that this revolutionized the study of the biomechanics, which is the main problem for many diseases in the cornea, namely the ectatic diseases and the keratoconus that follows laser vision correction. So the principle of the Prolween microscopy, which is a non-invasive, non-contact way, based on the principle that the cells of any tissues, they are not in a static state. They are in a dynamic state due to movement of the atoms and movement of the electrons in the atoms. Now, this continuous vibration of these electrons will create very low frequency vibrations known as the acoustic phonons. Now, this acoustic phonons has a very low frequency that cannot be picked up easily, because this technique of Prolween microscopy was invented in the late 60s, 1960s. But at that time, it was difficult to pick up this acoustic phonons that reflect the specific viscoelastic property of the tissue. Each tissue has its own mechanical property and viscoelastic property, and this is proportional to the vibration of this acoustic phonons. Now, the principle of Prolween microscopy that we can stimulate these atoms and this acoustic phonons using a near-infrared laser beams, and these laser beams will be reflected back and backscattered, known as the Prolween backscatter or Prolween shift. Now, if we can determine the difference between the ongoing rays and the outgoing rays by specific spectrometer, we can study the viscoelastic property of the tissue. Now, at that time, in the late 1960s, they could not pick up the reflected rays because, as I said, there was a very low frequency scattering of the rays, so it was not easy to pick up these rays. But now recently, there's one company that formed what's known as VIBA system, which stands for Virtual Image Prolween Amplification System, that it will amplify this reflected backscatter Prolween spectrum. And by this amplification, it can be detected by Prolween spectroscopy and then displayed in a three-dimensional map that represents the viscoelastic property of the tissue. This is the principle of the Prolween microscopy, that we cap the backscattered rays, which is known as the Prolween shift, and then undergoes amplification using the VIBA. And after amplification, it will be picked up by spectroscopy, special Prolween spectroscopy, and then displayed in a three-dimensional map. You can see that this is example for different types of keratoconus: mild, moderate, severe keratoconus. And this is the map as seen by Prolween microscopy that shows the viscoelastic property of each tissue. This is the normal cornea. You can see the color displayed, which is represent the gigahertz. Now the reflected rays are in gigahertz. So the dark blue color indicate this is normal cornea, and this is light blue color indicate mild keratoconus, and this is blue and red on the top of blue colors indicate severe advanced keratoconus. So this technology utilizes near infrared laser around 780 nanometer, and the backscattered rays is picked up by special detector and get amplified and then displayed. This is the basic principle of Brodwin microscopy that offers a high resolution three-dimensional map. This is diagram shows the mechanism of action of the Brodwin microscopy. As I said, there is stimulation by a near-infrared laser beam, and then it's scattered back. Now the spectral shift and the difference between the ongoing and outgoing rays get amplified by this Viber system, and this amplification enable the spectrometer to pick up these rays and display them in a three-dimensional map. And you can see this is the in-face image of the Brodwin microscopy, and the color code related to the gigahertz frequency, and the color code represent the viscoelastic property of the tissue. This is as simple as that. Now, the advantage of Brodwin microscopy that, as we said before, that the keratoconus is not a global disease of the cornea, but it is a focal defect in the biomechanics of the cornea. So from looking to the cycle of biomechanical decompensation, there is a focal defect in the cornea, and this focal defect will lead to distribution of the stress around that point that lead to thinning of that point, and then this thinning will lead to redistribution of the stress around that point, and that will lead to a focal steepening. And then this focal steepening will further lead to redistribution of the stress and so on. So this is a vicious circle, started from a focal defect in corneal biomechanics and end up by steepening of the cornea. So now by studying the whole property or the biomechanical property of the cornea, we can determine this focal defect in the cornea, and this opens the door for a customized treatment that we can customize the treatment that we will discuss about it later to target this focal area only. And if we break this and treat this focal area, we'll break this vicious circle. The same thing they discovered that in patients with implanted with intracorneal ring segments for keratoconus, because of the implantation of the segments will redistribute the stress around this point, so this will lead to a rest of the progression of the disease and break this circle. That's why they note that some people, upon implantation of the intracorneal rings, the progression of the keratoconus is stopped and arrested even without cross-linking. That's why sometimes intracorneal rings plays a role in the arrest of progression of keratoconus. Now, for us as in cross-linking, it is important for us to study the corneal biomechanical changes that happens before and after cross-linking, so that we can objectively confirm that there is real steepening or real stiffness of the cornea. By Brodwin microscopy, it provides information about the viscoelastic property, namely the longitudinal modulus, Brodwin longitudinal modulus. This is named given for the index that is explains the viscoelastic property of the cornea after using the Brodwin microscopy, known as the Brodwin longitudinal modulus, elastic modulus. Now, this is in contrary to the Young's elastic modulus. There's some difference between the Young's elastic modulus, which utilizes the mechanical stress strain test. In the Young's elastic modulus, it uses the standard traditional strain stress test that mechanically exerted into the tissue, and based on the slope and the curve between the strain and stress, they can extract the Young's elastic modulus. However, in the Brodwin microscopy, as I said, there is no any mechanical compression to the tissue. We just used an infrared laser beam. So this is in brief how the mechanism of Brodwin microscopy and what are the applications. And for us now, as we are speaking about cross-linking, this is very useful tool to determine the efficacy of your cross-linking by studying the changes of the Brodwin microscopy and the longitudinal elastic modulus of Brodwin before and after cross-linking to objectively determine the stiffness effect of cross-linking. Now, when we speak about the failure of cross-linking and when to do re-cross-linking, we can divide the failure to cross-linking into an early failure and late failure. The early failure can be seen within the after the initial 6 months after cross-linking. When you examine the patient, you will find no much haze can be seen in the cornea, and there is further increase in the curvature of the or the power of the cornea of 3 or 4 diopters, so that this is clear documented still failure of your cross-linking, and you should carry out re-cross-linking again. However, if your patient becomes stable and no more changes in the keratometry, at that time you can take out the next step in your armamentarium in the management of keratoconus in the form of contact lenses, or you can use any laser vision correction. Or if you notice that there is a progressive improvement in the K reading of the patient, so you will wait for some time, and after the stability you can go ahead and do contact lenses or whatever to improve the best corrected visual acuity of your patients.
Now, after understanding the important determinants for a successful cross-linking technique in the form of the way of delivery of the riboflavin, the concentration of the riboflavin, whether we do epithelial on or epithelial off technique, presence or absence of oxygen or pulsed oxygen, the effluence and the light intensity, all these variables are very important to guarantee the success of your cross-linking techniques. But now the question in mind that whether how long is your cross-linking technique will stay. And before we answer this question, we have to understand what are the high-risk group that are prone for further progression even after cross-linking. Now, among these factors, which is an important factor, is the age of the patient. Now, the younger the age of the patient, which is inversely proportional to the stiffness of the cornea, the more the risk is for progression. And the older the age of the patients, the less the risk of progression. And this is very important to understand because in younger age groups, there might be coexistence of some diseases like spring catarrh or vernal keratoconjunctivitis. Also, the turnover and the remodeling process in the corneal collagens are very fast and very intense in children. So that many studies shows that most of the children after 3 to 4 years, some studies 5 years, they will need redo for their cross-linking again. And this fade off of the effect of the primary cross-linking is related to the lay down of the new collagen fibers. Now, the older group of people, because we have two variables now, the effect of the cross-linking as well as the age-related or the physiological cross-linking related to the age. So this is very important factor. So to determine the high-risk group, we have to look to the age of the patients. We have to look females with pregnancy or lactating women are at high risk, and also the presence of eye rubbing. Now, it is very important that to inform your patient to stop eye rubbing, otherwise the risk of recurrence will be more. Now, some other diseases like trisomy 21, the presence of cigarette smoking. Now, the heavy chain smokers have a positive impact on the cross-linking, that they have less the need for cross-linking because the cigarette smoking, by the process of aldehyde condensation of the collagen fibers, so this will protect the patient from progression after cross-linking. And also the presence of what's known as the sensitive estrogen receptor modulators. Some people, they have this receptors in special malignancies like the breast cancers. So these people, they notice or show deterioration of the keratoconus even after cross-linking. So all these variables are very important. These people are at high risk for progression even after cross-linking. Now, as I said before, that we have to understand that the lay down of new collagen fibers, as studied by the physiological studies of the collagen fibers, that maximum by 5 to 7 years, you will have new collagen fibers inside the cornea and no more cross collagen fibers will be available. Now, the other question is that how can we classify the failure of cross-linking as a primary or secondary failure? The most of the studies that studied the people who went re-cross-linking after a primary failure define the progression or the failure of the primary cross-linking based on the tomography. That's to say, more increase in the Kmax more than 1.5 diopter, or the steep K reading more than 1.5 diopter, or the refractive astigmatism more than 1.5 diopter, or drop in the best corrected visual acuity for more than 2 lines. Now, this is in contrary to the progression criteria for keratoconus per se without cross-linking. If you see the progression criteria for keratoconus, little bit differs than the progression criteria after a primary cross-linking. However, now the evolution of the ABCD display, progression display by Billin and Plosio, who mainly depend on the ABCD criteria. That's the anterior surface curvature, the posterior surface curvature, and the corneal thickness, and also visual acuity as independent factor. Now, in the ABCD progression display that we have spoken about it before, they don't rely on the Kmax as in the old progression criteria. They just depend on the ABCD system. And the reason for that the Kmax is not a sensitive predictor of the progression, because you might have changes in the thickness of the cornea and the posterior surface of the cornea without any changes in the anterior surface. Now, the Kmax represents the anterior surface. So you might have progression without changes in the Kmax. And this is documented in many cases. That's why the trend is toward the use of the ABCD system. Although, as I have mentioned earlier, that now the new trend is toward the use of biomechanical changes. Now, the people behind that, they say that the biomechanical stability precedes the tomographic stability. So, to document the progression of after primary cross-linking, we have to check the corneal biomechanics. If we find a very good corneal biomechanics and the difference map between the preoperative and the postoperative changes in the corneal biomechanics will give us a clue about the need for another cross-linking or not. So this should be kept in mind, and you should also, when you decide to do re-cross-linking, to keep in mind that the primary cross-linking will cause some reduction in the thickness of the cornea, and this is perhaps due to the stretch or the stiffness of the collagen fiber, so there will be a reduction in the stiffness of the cornea. So you have to guarantee the safety profile of your thickness of the cornea before you decide for another re-cross-linking for your patients. So you should differentiate a real progression after a primary cross-linking from the pseudo progression. Now, what's the meaning of pseudo progression after cross-linking? That immediately within the first 1 month after cross-linking, you will find all the parameters will be worse in the form of the Kmax, the steep K reading, the curvature, and the thickness of the cornea, and the visual acuity. All these parameters will be reduced. And so you need to check your patient after 6 months. Now, after 6 months, now you can decide whether your patient is stable or in a state of progression. But before 6 months, you cannot decide, because the noise variables for your assessment is very high, and you cannot rely on the parameters during the initial 6 months. And that's why this is named as pseudo progression, especially if the patient has brain catarrh. If you use a epithelial longer duration during your technique, so there will be dehydration of the stroma. So this will affect your tomographic data, and the remodeling and the haze that happens after the procedure will affect your tomographic data. So any diagnosis of true progression should be decided after 6 months from the primary cross-linking. As I said, that to define the longevity of your cross-linking, we have to divide the failure of cross-linking to an early failure and late failure. And the reason behind that for early failure, there are certain reasons which happens usually due to the procedure itself, the way that you have done the cross-linking, the concentration of riboflavin, the availability of oxygen, the fluence and the intensity of your ultraviolet, and so on. So if you find within the first 6 months that the patient is progressing, increase in the K reading, increase in the steepening of the cornea, marked drop in the visual acuity, so this means that you have an early failure and you need to study re-cross-linking, and usually this is done after 6 months. Now, if you find no haze, no demarcation lines, and deterioration in the K reading, so you need to do or study the re-cross-linking. Now, after 6 months, you have two options. Either you have your patient is stable as compared to the preoperative data, there is no further any increase in the K reading, or sometimes you find improvement in the K reading. There is a flattening of the K reading with improvement of the visual acuity. Now, both of them are regarded as successful cross-linking, and you have to follow your patients and plan for what's the next step to improve his visual function in the form of another laser vision correction or the use of contact lenses or whatever procedure to improve his visual function. This is the roadmap how to proceed after successful cross-linking. Now, for late cross-linking late failure is due to the decay of the effect of the cross-linking, and this is expected because, as we said, that cross-linking is not forever. Cross-linking is based on the how much tissues that you have cross-linked, and depends on the lay down of new collagen fibers in the cornea. Most of the studies shows that between 7 to 10 years you can guarantee 95% stability of your cornea. And also the studies done on the physiology of the collagen fiber synthesis in the cornea, they say that collagen fibers are resynthesized, or the half-life for 5 to 7 years. So this is theoretically means that by 7 years you have no more cross-linked collagen and you have totally new collagen fibers in a process called rejuvenation or regenerations. So this is an example. If you have a patient that you cross-link him at the age of 32 years, so if we say that the success will be for 5 to 10 years, so by the age of 40 years, he will the CXL effect will fade away, and the patient will be stable, not because of the effect of the cross-linking, but because of the age-related stability and the stiffness of the cornea in the process which is known as physiological cross-linking. Although this term physiological cross-linking, some people they regard it as a myth in the management of cross-linking and the management of keratoconus, because they still can see cases even after the age of 45 years and they have progressive keratoconus. So the issue of stability after this age should be decided with caution, and this can be even visible by serial follow-up. Now, the problem that if you cross-link a patient at a younger age group, for example, at the age of 12 years, so if we say that the effect will stay for at maximum, at best situations in the children for 5 years, so by the age of 17 or 18 years, the effect of the cross-linking will fade away, and at that time you will notice that there is a progression of the ectasia and the steepening of the cornea, so you have to plan for another cross-linking. Keeping in your mind that the children are not young adults, so the anatomy and the physiology of the cornea in the children is totally different than in adults, and the remodeling of the tissues and the effect of the cross-linking is different than in adults. So many studies done on young children, they found that the effect will at maximum 5 to 6 years. So if you do a young child, you might need another 2 or 3 cross-linking during his life to guarantee the stability of his cornea. So this is the longevity of cross-linking. And there is a website where there is an online calculator made by the Morphedes Hospital. This calculator, based on the demographic data of the patients, they're based on his age and K reading, they can expect how long your cross-linking will stay, so that you can have an idea and plan for secondary cross-linking or redo cross-linking for your patients. So in conclusion, the failure after cross-linking can be divided into early failure and late failure based on the onset, as well as based on the etiology behind it. The early failure is usually within the first 6 months after primary cross-linking, and usually might be related to the technique that you have used during the cross-linking technique, whether it is epithelial on or epithelial off. It might be related to the poor concentration of the riboflavin that you used, or due to the poor oxygen supplementation, and many factors related to the technique itself. This will lead to a primary failure of your cross-linking. Also, it might be related to the age of the patients and the coexistence of certain diseases and morbidity, like the presence of active spring catarrh and active vernal conjunctivitis. or some endocrinal disturbance like the hypothyroidism and also the pregnancy and lactating women's, and presence of trisomy 21 like Down syndrome. All these are related to the primary failure. The late failure, which is related to the decay or the longevity of the cross-linking effect. Now, cross-linking is not forever. The effect will fade up after a certain period of time, and this is due to the lay down of the new collagen fibers in a process known as regeneration or rejuvenation. This process means that between 6 to 7 years, maximum up to 10 years, and most of the studies, they show stabilization of the cornea in 95% of the cases for 10 years. This stabilization is due to the cross-linking of the collagen fibers, but after this period, there will be laid down of new collagen fibers, and nearly new collagen fibers will be present in the cornea by that time. So the cross-linking effect will be fade off, and no more stabilization or stiffness in the cornea. So based on the age of the patient, you have to decide to carry out a second procedure of cross-linking, or it might be get intermingled with the age-related stiffness. So if the patient passes the 40 years of age, sometimes the stiffness related to the age will overcome this problem, and there will be no more further progression of the keratoconus because of the what's known as physiological age-related cross-linking. So it's important for us to know what are the parameters that indicate that there is a primary failure of your cross-linking, so that you can decide for redo of cross-linking. What's available now in many studies that they rely mainly on the topography or the tomography, namely changes in the Kmax more than 1.5 diopters, or the steep K reading more than 1.5 diopters, or in the refractive astigmatism more than 1.5 diopters, or the best corrected visual acuity dropped by more than 2 lines. However, the new display of the ABCD progression display, they don't rely on the Kmax, but they rely on different variables. That's the curvature of the anterior surface and the curvature of the posterior surface and the corneal thickness. And after 12 months, we can follow the patients after 12 months from the cross-linking. And based on that display, we can determine whether the patient is in need for another recross-linking or not. This display is known as the ABCD progression display, invented by Pellin and Prosser. Now, also there is a new trend towards the use of corneal biomechanics to evaluate the progression or the stability or the efficacy of your cross-linking, claiming that the people who are claiming that the corneal biomechanical stability precedes the geometric or tomographic corneal stability, as we have explained before in the what's called the elasticity factor, which has been recently added to the ABCD progression display. And in the future, we need more studies to on solid ground. We can say that follow up by the biomechanical changes is more efficient way of determining the efficacy of your cross-linking, rather than totally depend on the tomography. So you can see the evolution of the assessment of the efficacy of cross-linking. Initially, they were totally dependent on the Kmax and the demarcation lines. After that, they discovered that the Kmax is not an accurate parameter to document progression, because sometimes there is a progression in the anterior surface or the posterior surface before any changes in the anterior surface, so that the Kmax will be stable, and you have a worsening of the posterior surface of the cornea along with a drop in the visual acuity. So the trend shifted toward the use of the ABCD display, that avoid the use of Kmax and uses another parameters to assist the progression. And then now they try to shift to another area, which is the corneal biomechanics, by establishing the new E factor, which is the elasticity factors based on the Young's modulus of elasticity, so that we can precisely early detect the progression after cross-linking and take intervention as soon as possible. The other point that in many studies, they found that the redo for cross-linking is a safer procedure. Just you have to keep in mind that after cross-linking, there will be some thinning of the cornea, and this is related to the tightness and the stretch of the collagen fibers. So when you decide to do re-cross-linking, you should to make sure that your corneal thickness is sufficient and beyond the risk factors for the endothelium, so that you can carry out another procedure. Some people, they advise to do re-cross-linking with the same technique that you have done in the primary cross-linking. Some people advocate in the presence of a borderline corneal thickness to use the transepithelial technique for re-cross-linking, but still there is a need for many studies to be carried out on this regard, because most of the studies show that more than 95% are stable after the primary cross-linking, and more than 95% are stable after the secondary cross-link. So there is no much cases of failure of cross-link. That's why you need the long-term studies to study the cases who failed after primary cross-linking, to determine what could be the etiology behind this, and what are the parameters and the criteria to restabilize them.
Now we come to the main bulk of this lecture, which is discussing the different protocols available for cross-linking. We will classify these different protocols based on different levels of classifications, and then we will discuss one by one. As I said, that there is different levels of classification. I will just mention what's available to understand and study these different protocols or techniques of cross-linking. Broadly, cross-linking can be subdivided based on the epithelium, or based on the protocol used, based on the presence or absence of the epithelium, or based on the protocols which is used, is it conventional or accelerated or so on. So this is a broad classification. And for the epithelial-based protocols, the most famous and the conventional protocol, which is the epithelial off technique, which is known also as the Dresden protocol, which is the prototype of all types of cross-linking, and this is the standard against which all the other cross-linking techniques are compared. The efficacy of other techniques all are compared with this conventional Dresden epithelial off protocol. The other is the epithelial on technique, which is an innovations so that to speed up the technique. As you know, the epithelial off protocol is a long procedure, needs around 1 hour, 30 minutes for instillation and impipation of riboflavin, and another 30 minutes for the ultraviolet exposure. So the doctors and the investigators looking for improving the convenience of these techniques by establishing what's known as the epithelial on technique. The epithelial on technique means that the epithelium is intact. It can be as a transepithelial technique in which the riboflavin is applied directly to the epithelium, or as intrastromal pockets, so that during the femtosecond laser, when they do the smile, they can combine it with intrastromal injection of riboflavin. The other protocol, which is based on the techniques, or the other classification based on the protocols, which is, as I said, the Dresden protocol, which is the conventional protocol. It has special parameters as far as the energy, the intensity, and the wavelength, and everything. The other is the EPI-on protocols, the accelerated protocols, which can be either an EPI-on or EPI-off protocols. This is an innovation to speed up the process of the classical conventional protocols. Also, there is special protocols for thin cornea, because the standard cases, there is no problem, but doctors facing the limitation of the 400 micrometer thickness of the cornea. As you know, keratoconus, you might face the case with the progressive keratoconus, but with very thin cornea. So there are some special protocols for thin corneas. We will discuss about them later. Also, the customized protocols. This is also a recent innovations in which we apply the ultraviolet energy with different profiles, maximum energy over the apex of the cone, and less energy over the intact cornea or the peripheral part of the cornea. This is called customized protocols. Also, there are different types. Also, the combined protocols in which we combine the cross-linking with other vision correction procedures like the LASIK, known as the extra LASIK or extra SMILE or extra PRK. So this is another innovation, so that we are targeting both the stability of the cornea as well as improving the vision of the patients. So this is the different classification and the different protocols. For us, in this lecture, we will divide the protocols or discuss the different protocols based on the evolution of these protocols. They are subdivided into a first generation cross-linking protocols, second generation, third generation, and fourth generation protocols. And this is based on the evolution and the time and how the innovations happens in the cross-linking technique, so that we reach to the fourth generation, which is now is used. So we'll discuss based on this classification based on the evolution. Now we come to the first conventional or classical protocol, which is known as the Dresden protocol. This is an epithelial off protocol using the room oxygen and ultraviolet intensity of 3 milliwatt for 30 minutes. This is as described by Thiocelar. Now, the first step in this protocol is to remove the epithelium either by the BRK or by blade or by alcohol, or even by femtosecond laser, and the removal of the epithelium of up to 9 millimeter zone. Then we will start doing impipation of the cornea with 0.1% isotonic riboflavin for 5 minutes. And we have to make sure about the corneal thickness, that after 30 minutes you have to check the thickness. If it is less than 400 micrometer, we have to add some drops of the PSS, so that this will swell the cornea, or use of hypotonic riboflavin. Now, if the thickness is more than 400 micrometer, we will proceed with the third step, which is the use of the ultrasound, ultraviolet energy. We use it at a wavelength of 370 nanometer, and this is the wavelength that is shows the high absorption spectrum for the riboflavin. And similarly, we'll use it for 30 minutes, and in between every 5 minutes we use isotonic riboflavin and some BSS drops. On completion of the procedure, as I said, the ultraviolet should not exceed 8 millimeter diameter, so that we preserve the limbal stem cells. On completion, we add a bandage contact lens with a steep base curve, so that we allow some space between the healing epithelium and the bandage contact lens. We can use antibiotics. Non-steroidal is prohibited because there is some reports on inducing corneal melting on applying directly into the stroma. Steroids are controversial. Some people, they defer the use of steroids for the first week, so that allow for the reaction and the photochemical reaction to take place inside the cornea. However, if you have persistent haze and significant haze, you can use topical steroids, so that you will reduce the inflammation inside the cornea. So this is basically the different steps in the classical conventional protocol, keeping in mind that this protocol is applied with the residual stromal bed of 400 micrometer. This is apart from the epithelium. If you have residual stromal bed less than 400, you have to use isotonic riboflavin. As we are speaking about the Dresden protocol, the conventional way of cross-linking the cornea, I just like it to show you our study on patients at the Tripoli University Hospital, that we follow them for 2 years between the year 2017 and 2019, who underwent Dresden protocol cross-linking. This is a retrospective study for around 54 eyes for 49 patients, and we follow them for 2 years, and we show that this technique is very effective in arresting the progression of the disease in more than 98% of the cases. And all the data and the results are available in the Arab Medical Journal, so you can go through and revise it. Now, after the many studies done on the classical Dresden protocol and the success that they faced for stabilizing the corneal geometry and the depth of the cross-linking that they found after the classical type, they start to think to how to refine and improve the procedure by avoiding removal of the epithelium of the patient, as they face some problems with the pain that the patient sustained after the procedure. Also the duration of the procedure, that you need a 30 minutes riboflavin application and another 30 minutes of ultraviolet, so a total 1 hour for one eye. The problem of removal of the epithelium also make it challenging for the doctors to do the procedure in the major theater because the risk of infection is there. So they start to modify and refine the procedure by trying to do what's known as the transepithelial crosslinking. They use the same protocol, the same energy, but with an intact epithelium. Now the challenges was that riboflavin is not reaching to a good concentration inside the cornea because of the limited permeability of the corneal epithelium. Also the presence of tight junction between the epithelial cells. This will limit the penetration of the riboflavin to the cornea. And as you know, if we don't have a good concentration of riboflavin inside the cornea, the effect will be limited of the cross-linking. As many studies done shows that the demarcation line only approximately 200 micrometer, which is much less than that seen with classical Dresden protocols. So because of this, they start to look out what are the facilities or the possibilities to increase the diffusion of riboflavin inside the cornea by modifying or adding some materials inside the riboflavin, like the benzalkonium chloride, the gentamicin, the chlorambutanol, and the trometamol. All these substances, they will loosen the tight junction between the epithelial cells, and this will facilitate and enhance the absorption of riboflavin inside the cornea. Also the use of ionotophoresis, or sometimes they think of bypassing the epithelium by injecting the riboflavin inside the stroma as a pocket inside the stroma. So they realized that there are a lot of parameters that determine the efficacy of the cross-linking based on the concentration of the riboflavin. So they start to modify, as I said, the content of the riboflavin by adding some material to increase the absorption, or by the use of ionotophoresis that we will speak about it later, or doing mechanical alteration for the epithelium that creates some pockets inside the epithelium so that it allow for the penetration inside the cornea. Other doctors, they start to modify the concentration and the type of riboflavin. They claim that they instead of using the thick strand, we will use another riboflavin with EDTA or with isotonic riboflavin. Also the use of hypoosmolar riboflavin will facilitate the penetrations, and use different concentration rather than 0.1%. Some other doctors, they try to think to compensate for the shortage of the absorption of the riboflavin. Shortage of the absorption of the ultraviolet from the intact epithelium, so that we will increase the power or the intensity of the ultraviolet. All these factors, among the increase the contact time, the duration, instead of 30 minutes, increase the duration of the riboflavin on the surface of the cornea. But all the procedures has a limited result as compared to the Dresden protocol. They show some improvement in the effect, but it's still the Dresden protocol remains the superior one as far as the efficacy. However, the intolerance of the patients and the pain encountered after the procedure make it challenging for the doctor to look after for any other alternative way to improve the efficacy of the cross-linking by increasing the diffusion of riboflavin inside the cornea. These are some of the advantages and benefits of doing, or the desire of the doctors to shift toward transepithelial protocols because of the reduction of the risk of infection. As you know, the epithelium is intact, so the risk of infection is less. Also, the reduction of the haze that is induced by the wound healing when you do scraping of the epithelium. Also, faster patient recovery and rehabilitation, and less pain because of the removal of the epithelium. And as I said, even the microstructural damage to the ocular surface is minimized with minimum inflammations and induction of mediators of the inflammations, and also preserving the nerve plexus of the eye so that the tear film production and the avoid the dryness of the eye. Simultaneous procedure can be done at the same time because there is no risk of infections. So you need not to do the operation in 2 steps or sequential steps, but only at the same time, and the two eyes can be done at the same time with quick rehabilitation and return of the patient to work. And also it can be as a full outpatient procedure with minimum cost to the patient. All these advantages of the transepithelial protocols make it the doctors eager to shift toward these protocols and trying to solve the problems that face them to apply or implement this protocol. As I said before, after the paradigm success in the classical Dresden protocol, now the doctors try to solve the problem of the duration of the procedure. As you know, the procedure is long time, needs 30-minute exposure to ultraviolet, to riboflavin, then 30-minute exposure to ultraviolet. So among the attempts to solve this issue, apart from the use of riboflavin as a transepithelium, they try to think to how to increase the intensity of the ultraviolet so that we will short the exposure time to the ultraviolet. And this was based on the law of Bunsen law of reciprocity. I will explain about it later, that we can increase the intensity of the light and shorten the duration of exposure, keeping the same amount of total fluence or total energy exposure. So this is the principle of the accelerated protocol. The accelerated protocol can be with the epithelial on or epithelial off, with pulsed or continuous mode. So the idea that we can, instead of the 30 milliwatts, that's in the classical protocol, we can use the 9 milliwatt intensity for 10 minutes, or 18 milliwatt intensity for 5 minutes, or 30 milliwatt intensity for 3 minutes. If you can see that if we multiply, the total will be about around 90. If you multiply the intensity with the time, so the amount will be equal to 90. So 18 multiplied 5 is 90, and 30 multiplied 3 is 90. So we keep the same amount of fluence. This is the total amount of energy is 5.4 joule. So we can adjust the intensity by increasing the intensity and reducing the time, but we keep the whole amount of energy exposure is 5.4. So this is what's meant by accelerated protocol, and this is based on Bunsen-Rusko law of reciprocity. I will explain about it later. Now, why the idea came? The idea that the need for a rapid protocols, because the standard protocol, as I said, is a time-consuming, more patient discomfort, and sometimes excessive dehydration, especially when using riboflavin with dextran for 30 minutes in the cornea. This might induce dehydration and lead to decrease in the corneal thickness. And the other thing is the advantages of this protocol, which is the accelerated protocol, by reducing the exposure time, improving the patient comfort, and less risk of infection, because with the accelerated protocol, we can use it transepithelium without the need for removal of the epithelium. So also many experiments done on animals, and they show the same biomechanical effect of the classical Dresden protocol with a 3 milliwatt for 30 minutes as compared to the accelerated protocol, for example, the 10 milliwatt or 9 milliwatt for 10 minutes. All these points support the trend toward accelerated protocols. As far as the accelerated cross-linking, the principle of accelerated cross-linking has been invented after understanding the physical law, which is the Bunsen-Rusko law of reciprocity. This law stated that the photochemical reaction or the biological reaction to an ultraviolet energy is proportional to the total amount of energy delivered, regardless of the applied radiance and time. So the total amount of energy, as long as the total amount of energy is the same, so the biological effect will be the same, regardless the amount of intensity and the time. So you can play with the time and the intensity as far as the total amount of energy is the same. This is the principle that makes doctors suggest different protocols for the accelerated cross-linking treatment. Now, this is not true all the time, because when they study the biomechanical effect of the cross-linking against various protocols available, of course, the best biochemical effect has been shown to be with the Dresden protocol, which is a 3 milliwatt for 30 minutes, as you can see here. And other protocols, for example, the 9 milliwatts for 10 minutes, this is accelerated cross-linking, also the 18 milliwatt for 5, and so on. So nearly the same. There is no much difference from the standard protocol. However, when you reach to the intensity of 30 for 3 minutes, there will be followed by marked decline in the biomechanical effect in the cornea. And this can be explained due to the depletion of oxygen. The more you go with high energy, the more the photooxidative reaction, and you need more oxygen. And as long as there is depletion of oxygen, so the biomechanical effect will be minimal. So the Ponson-Roscoe law of reciprocity is not always proportional. It is limited with these values that beyond 30 milliwatts, it is no more valid. So this is very important to be understood. And the reason for that, as I said, that because of the oxygen depletion. بهذا القدر نصل إلى نهاية الجزء الأول من محاضرة Corneal Collagen Crosslinking. We just finished the section A of this lecture, and I will meet you in the second section, that is section B. We will discuss in section B the third and fourth generation Corneal Collagen Crosslinking, and we will discuss in details about the recent advances in crosslinking techniques. To that level, I hope that you will be safe, and I hope that I will meet you very soon.